Hello everyone. Today we will looking into trauma and stressor related disorders. Many of the psychological difficulties we experience in everyday life are closely connected to stress and traumatic experiences. In particular, traumatic events go beyond simple discomfort and can have a profound impact on person's thoughts, emotions, and overall behaviors. In today's lecture, we will first explore the concept of trauma and stress-related disorders and then go through specific conditions one by one. For example, we will cover adjustment disorder, acute stress disorder, post-traumatic stress disorder, attachment-related disorders, and finally, disorders associated with prolonged grief. First, it is important to clearly understand the difference between trauma and stressor. Trauma refers to direct exposure, witnessing, or repeated encounters with extremely thrilling events such as actual death, serious injury, or sexual violence. On the other hand, a stressor does not necessarily involve a threat to life, but refers to significant life changes or stressful events such as divorce, job loss, or moving. Although these experiences may not meet the strict criteria of trauma, they can still cause considerable psychological difficulty and impairment. Such traumas and stressors can lead to various psychological disorders. On the right side of slide, you can see the main trauma and stress-related disorders. The category of trauma and stressor-related disorders was first introduced as an independent diagnostic classification in DSM-5. The common feature of this category is that the symptoms always emerge after exposure to traumatic or stressful events. In DSM-4, PTSD and acute stressor disorder were included under anxiety disorders. However, in DSM-5, they were separately into their own category. The reason for this change was to highlight that these disorders cannot be explained solely by anxiety symptoms, but rather have distinct causes and symptom patterns. In other words, DSM-5 emphasizes the causal role of trauma and stress, and thus treats these disorders as a major independent diagnostic category. The first specific disorder we will examine is adjustment disorder. Adjustment disorder is generally defined as the presence of emotional or behavioral symptoms that occur in response to stressful event. The symptoms begin with 3 months after the event and usually do not persist for more than 6 months once the stressor is removed. Typical symptoms include depressed mood, anxiety, and difficulty adjusting to daily life. In severe cases, there may be an increased risk of suicidal thought. So, what types of stressor can lead to adjustment disorder? Examples include the breakup of a romantic relationship, job-related problems, or marital conflict. Stressors may be one-time events, but they can be also repetitive or chronic. Chronic illness or living in adverse environments for a long time can also act as risk factors. Developmental transitions are important as well. Life changes such as starting school, separate or reunification with parents, marriage, becoming a parent, job failure, or retirement can all trigger adjustment disorder. Adjustment disorder cannot be explained merely by the stressful event itself. Rather, it depends on the meaning of the events for the individual and the person's own vulnerabilities. First, the nature of the stressor plays a key role. The same event may be manageable for one person, but deeply distressing for another. Second, an individual's subjective interpretation and unconscious processing of the stressful events also affect the outcome. In addition, personal vulnerabilities such as certain personality traits or neurological factors like brain injury can increase risk. Third, early adverse experiences are also important. For example, losing a parent during childhood or growing up in a dysfunctional family can make a person more vulnerable to stress later in life. Ultimately, adjustment disorder arises not only from the event itself, but also from the interplay of a person's developmental background, psychological characteristics, and neurological conditions. The treatment of adjustment disorder focuses primarily on psychosocial support. Group therapy, in which individuals share experiences with another who are going through similar stress, can provide mutual support and significant aid to recovery. Another important aspect to consider is secondary gain. For example, the rewards or attention to patient may receive by adopting the role of sick person can reinforce their symptoms. Clinicians need to carefully evaluate this factor. Medication is usually considered a supportive measure. If depressive symptoms are prominent, antidepressants may be prescribed. If anxiety is severe, anti-anxiety medication may be used. However, such medications are generally prescribed for only a short period and are combined with psychotherapy. Ultimately, the goal of treatment is not merely to reduce symptoms, but to help individuals adapt to stressful events in a healthier way. Now, the next topic we will look at is acute stress disorder, in short, ASD. This disorder refers to the psychological reactions that appear for a relatively short period of time immediately after a traumatic event. Acute stressor disorder develops right after a person is exposed to the trauma. The symptom may begin immediately or within just a few days. What really matters is the duration. The condition is only diagnosed when the symptoms last between 3 days and 1 month. If the symptom continues beyond 1 month, then the diagnosis changes to post-traumatic stress disorder or PTSD. The symptoms of ASD are grouped into 5 main domains. First, there are intrusion, where the trauma keeps coming back through unwanted memories, flashbacks, or nightmares. Second, we see negative mood, meaning that person finds it almost impossible to feel positive emotions. Third, dissociation may occur. In this case, reality feels altered or part of the events cannot be remembered. First, avoidance behaviors are common as people try to stay away from thoughts, memories, or places connected to the trauma. And finally, arousal symptoms appear, such as sleep difficulties, irritability, hypervigilance, or trouble concentrating. To put it simply, acute stress disorders show patterns very similar to PTSD, but it appears sooner and lasts for a shorter period of time. The key part of the diagnosing both acute stress disorder and PTSD is what we call criterion A, the presence of traumatic events. So, what kind of events fall into this category? They include natural disasters such as earthquakes, tsunamis, typhoons, or floods, events that clearly threaten lives. They also include serious accidents like car crashes, industrial accidents, or plane crashes. Interpersonal violence is another major cause. Physical assault, sexual assault, and domestic violence all belong here. War and combat experiences are also powerful sources of trauma, affecting not only soldiers in battle, but also civilians living in war zones. Another extreme act of violence, such as terrorist attacks or mass shootings, are also included. Witnessing someone else being seriously injured or killed counts as well. Finally, there are occupational exposure. First responders, firefighters, or police officers who are repeatedly exposed to traumatic situations are also included under criterion A. So, to summarize, criterion A does not simply refer to stressful events. It specifically requires events that involve real, severe threat to life or significant physical danger. Whether acute stress disorder develops or not depends on not only the event itself, but also on the individual's vulnerability and circumstances. The severity and types of trauma plays a big role. For example, direct and personal threats such as interpersonal violence and sexual assault tend to carry higher risk, although natural disasters and accidents also apply. Past experiences matter too. A history of trauma or pre-existing mental health problem increases the likelihood of developing ASD. Strong associative reactions immediately after the trauma, such as feeling unreal or being unable to recall what happened, are also a risk factor. A lack of social support is another major factor. When people have weak support systems or are dealing with ongoing stress in their lives, they become more vulnerable. Finally, biological vulnerability also plays a role. For instance, if a person's stress response system is overly reactive, or if the HPA axis is poorly regulated, this can increase the risk. So overall, acute stress disorder does not arise from the traumatic event alone. It emerges through the interaction of personal, environmental, and biological factors. Next, let's talk about approaches to support and intervention. First of all, it is important to carefully assess the patient early on and monitor symptoms to understand how well they are functioning. Psychological first aid focuses on ensuring safety, providing a sense of calm, and helping the person connect with appropriate support systems. In the short term, trauma-focused cognitive behavioral therapy has been shown be effective in reducing the risk of developing post-traumatic stress disorder. However, one caution here is the practice of single session debriefing. This involves gathering people right after the trauma and encouraging them to talk about their experiences in a single meeting. Research has found that this is not necessarily helpful and may even worsen symptoms, so it is not recommended as a routine practice. When severe anxiety or insomnia is present, short-term use of medication can be considered carefully but always with caution. Ultimately, strengthening social support, building coping skills, and gradual helping individuals return to normal daily activity are key elements that promote recovery. So far, we have looked at acute stress disorder. Now we will move on post-traumatic stress disorder or PTSD, which is the long-term conditions that develop after traumatic events. Post-traumatic stress disorder always begins with exposure to a traumatic event. In other words, there must be a criterion A, events such as actual or threatened death, serious injury, and sexual violence. The symptoms are grouped into 4 clusters. First is intrusion. The individual repeatedly experiences unwanted memories, nightmares, or flashbacks, and feels intense distress when confronted with reminders of the trauma. The second is avoidance, where the person makes an effort to avoid trauma-related thoughts, feelings, people, or places. The third cluster involves negative alternations in cognition and mood. This may include guilt, fear, distorted self-blame, persistent negative emotions, or a sense of detachment from others. Finally, there are alternations in arousal and reactivity. People become irritable, more easily startled, prone to anger, and they often experience problems with concentration and sleep. These symptoms must last for at least 1 month to warrant a diagnosis of PTSD. If the reaction lasts only a few days or a week, the condition may instead be diagnosed as acute stress disorder. An additional requirement is that the symptoms cause significant distress or functional impairment. When a person's ability to work, maintain relationships, or perform academically is substantially impaired, PTSD must be considered. PTSD also includes specifiers, which are labels added to the main diagnosis to describe the particular form that the disorder takes. The first specifier is depersonalization. This refers to the feeling of being detached from oneself, as if one's thoughts, emotions, and actions belong to someone else. For example, a person may feel that the reflection in the mirror is not their own, or they are watching their actions from a distance. The second specifier is derealization. This is the sense that the external world feels unreal or dreamlike. The environment may appear unfamiliar, or sensory experiences may feel distorted. Both depersonalization and derealization are considered dissociative symptoms. In such cases, simple exposure therapy may actually worsen the condition. So, stabilization techniques and grounding methods that restore a sense of reality are essential before exposure can be attempted. Another specifier is delayed expression. This applies when the diagnostic criteria are eventually met, but the symptoms do not become fully apparent until at least 6 months after the trauma. This pattern is often seen among combat veterans or survivors of sexual violence. Because symptoms emerge later, early intervention is difficult. So, making long-term monitoring particularly important. Let us now turn to the causes and risk factors of PTSD. The first involves individual vulnerability, temperament, personality traits, childhood trauma, or pre-existing personality disorders can all increase the risk. The second relates to occupational risk groups. Professions such as firefighters, combat soldiers, and emergency responders are more likely to develop PTSD due to repeated exposure to traumatic situation. The third involves biological factors. Trauma can induce changes in both the brain and the body. For example, abnormal responses to stress hormones such as cortisol or norepinephrine may occur, and the dysfunctions in the hippocampus or prefrontal cortex can impair memory and stress regulation. The first factor concerns the characteristics of trauma itself. The intensity of the event, the proximity of the experience, and the duration of exposure all influence risk. The fifth involves post-trauma factor. Limited coping skills, insufficient social support, or ongoing stressors such as family or workplace conflict can exacerbate symptoms. Finally, there are protective factors. Higher intelligence, strong resilience, and the presence of supportive social networks can reduce the likelihood of developing PTSD. Now we will examine the method of support and intervention that can be provided to patients with PTSD. The first is stress inoculation training. This method reduces vulnerability by allowing individuals to practice coping skills in advance, preparing them to handle stressful situations more effectively. The second is crisis intervention. Immediate support following a traumatic event is essential for restoring a sense of safety, for preventing symptoms escalation. The third is psychological debriefing. This involves a structured session in which individuals share their traumatic experiences and emotional reactions, recognizing and processing their responses. When necessary, referral to a professional is also included. However, it is important to note that psychological debriefing is not universally effective and therefore should be applied with caution. The next area concerns psychotherapeutic approaches. Cognitive behavior therapy has been proven effective in addressing trauma-related fear, anxiety, and distorted belief. A central component of CBT is repeatedly and safe exposure to traumatic memories, which helps individuals confront their experiences and gradually reduce avoidance and fear. In addition, CBT facilitates the restructuring of trauma memories so that they can be integrated into the individual's existing belief system. Another important approach is cognitive processing therapy, or CPT. This method focuses on correcting distorted beliefs about the causes and consequences of trauma. By re-evaluating the event and modifying its negative meaning, CPT reduces the intrusive impact of traumatic memories. Finally, we turn to specialized intervention. Trauma-focused CBT is an approach specifically developed for children and adolescents. The process unfolds in 3 phases. The first is stabilization, in which individuals learn skills for safety and coping. The second is trauma processing, where the traumatic event is narrative and cognitive restructured. The third is integration, which emphasizes recovery through family support and the reestablishment of meaning. Another method is eye movement desensitization and reprocessing, in short, EMDR. This technique involves recalling traumatic memories while simultaneously engaging in guided eye movement. The treatment proceeds step by step, preparing an assessment, desensitization, installation of positive beliefs, body scanning, closure, and reevaluation. EMDR has been shown to reduce the emotional intensity associated with traumatic memories. We will now examine disorders related to childhood attachment, beginning with reactive attachment disorder, or RAD. Reactive attachment disorder is a condition that primarily appears in children and is characterized by distinctive patterns in the relationship with adult caregivers. Children with RAD tend to be emotionally withdrawn and rarely seeking emotional comfort from caregivers. Ensuring little response even when comfort is offered. They also display persistent social and emotional difficulties. These may include showing minimal emotional responses to others, rarely expressing positive emotions, or exhibiting unexplained irritability, sadness, or fear, even in non-threatening situations. The disorder most often develops in situations where caregiving is grossly inadequate. For example, it may occur when a child's basic emotional needs, such as comfort, stimulation, and affection, are consistently unmet. It can also arise when the primary caregiver changes a lot, making it difficult for the child to form a stable attachment. The further context is institutional care, where a high child to caregiver ratio severely limits opportunity for selective attachment. In short, RAD emerges when a child lacks the opportunity to establish secure and stable bonds. The origins of reactive attachment disorder are rooted in attachment trauma. When the relationship between the child and the caregiver is disrupted or unstable, the children's capacity to differentiate self from others and to build a healthy relationship is impaired. In particular, if caregivers fail to provide consistent and appropriate responses, the children's emotional development is hindered and the ability to form attachment behavior toward others is weakened. Effective treatment requires careful attention to the interaction between the caregiver's behavior and the child's response. It is also important to examine how parenting style and the child's temperament influence attachment formation. Furthermore, the fit between caregiver and the child is that the strength and weakness in their interactions should be assessed. Because children with RAD may respond to caregiver behavior with anger or anxiety. So, caregiving must be approached with great sensitivity. Ultimately, effective treatment and care focus on enabling the child and caregiver to engage in consistent, sensitive, and reciprocal interaction. The next disorder to be considered is disinhibited social engagement disorder, or DSET. Like reactive attachment disorder, DSED is also closely connected to difficulties in the formation of attachment during childhood. The core feature of disinhibited social engagement disorder is that children display excessively familiar and uninhibited behavior toward unfamiliar adults. They show little or no hesitation when approaching strangers and may engage in socially inappropriate verbal or physical familiarity. In addition, in new environments, they tend not to check back with or rely on their caregivers, and at times, they may even follow an unfamiliar adult without any apparent hesitation. This parent stands in marked contrast to what is expected in normal attachment development. This disorder is also strongly associated with experiences of inadequate caregiving. For example, it may develop when children are deprived of comfort, stimulation, or affection, when the primary caregiver changes repeatedly so that stable attachment cannot be established, or when children are raised in institutional settings where high child-to-caregiver ratio limit opportunities to form selective attachment. In such an environment, children fail to learn appropriate boundaries and instead displays indiscriminate familiarity toward others. Although this inhibited social engagement disorder, like reactive attachment disorder, arises from deficiencies in caregiving, the two differ in temperament and behavior presentation. Children with reactive attachment disorder tend to appear withdrawn and emotional inhibited, whereas children with disinhibited social engagement disorder show indiscriminate friendliness and impulsiveness. These children often seek temporary comfort from unfamiliar adults as a way to cope with loneliness and fear. However, such interactions are superficial and maladaptive, and they may lead to rejection or further neglect. Accordingly, treatment and intervention focus above all on building stable and consistent relationships with caregiver. The essential goal is to provide the child with a predictable and safe environment in which healthy attachment can be relearned. We will now turn to one of the diagnostic categories more recently added to the DSM-5-TR, named prolonged grief disorder. It is natural for anyone to experience grief after the loss of a loved one, and in most cases, the intensity of grief gradually decreases with time, allowing the person to recover. However, in some cases of the grief persists for a very long period and severely disrupt daily functioning. This condition is defined as prolonged grief disorder. The core feature of this disorder is the persistence of intense yearning for or preoccupation with the deceased. According to DSM-5-TR, the symptoms must last for at least 12 months in adults and for at least 6 months in children and adolescents. Specific symptoms include identity disruption, such as feeling as though part of oneself has died, persistent disbelief regarding the death, avoidance of reminders of the loss and ongoing emotional pain, such as anger, bitterness, or deep sadness. Individuals may also struggle to re-engage socially, find it difficult to interact with friends or to make plans for the future. Additional features, including emotional numbness, a sense of that life is meaningless without the deceased, or profound loneliness. An important concept associated with prolonged grief disorder is dual process model, proposed by Margaret Strube and Hank Schutt in 2010. This model suggests that people coping with loss alternate between two types of coping. One is loss-oriented coping, which involves directly confronting the pain of the loss. For example, remembering the deceased and experiencing sadness and anger. The other is restoration-oriented coping, which involves adapting to a new reality by rebuilding daily life, engaging in social activities, and re-establishing a sense of purpose. The essence of the model lies is oscillation. Individuals move back and forth between these two modes, like a pendulum, gradually find balance. This means that healthy grieving does not consist of completely overcome grief, but of integrating the experience of loss into one's ongoing life. This figure illustrates the dual process model visually. On the left side is loss-oriented coping, and the right side is restoration-oriented coping. In daily life, individual oscillation between these two models, and through this movement, they gradually process their grief. For example, at one moment, a person may be immersed in painful longing for the deceased, while at another moment, they may engage in setting new goals or interpreting positive experiences as part of rebuilding life. The model demonstrates that grieving is not a linear process, but one that moves back and forth until integration is achieved. In this lecture, we have examined a range of trauma and stress-related disorders, considering their defining features, causes, risk factors, and method of intervention. What is most important to emphasize is that these conditions are not simply abnormal reactions, but rather natural human responses to extreme stress or profound loss. In clinical practice, our task is not limited to assigning diagnostic labels, but to understand the individual's lived experience and support recovery through appropriate intervention. I hope that today's lecture helps you understand the suffering of clients more deeply, whether in clinical encounters or in research, and that it provides guidance for offering more effective care. That concludes the lecture. Thank you for your attention.